So the next question is on the deep tendon reflexes. During physical assessment of a 55-year-old male with low back pain, the quadriceps reflex was absent. Which of the following nerve roots is most likely to be affected? L2, L5, L4, S1. So you need to be aware that it is L4, which is a major root value for the knee jerk, that is the quadriceps reflex. So now you need to know what are the various root values of various deep tendon reflexes. First and foremost, you take the biceps jerk. The root value is C5 and as well as C6. And the triceps jerk, the root value it is mainly like C6 and as well as the C7, that is for the tricep jerk, to a certain extent even C8 as well. And brachioradialis jerk or the supinator jerk, that will be C5, C6 again, like similar to that of the biceps. So this will be like upper limb deep tendon reflexes, whereas you take the lower limb deep tendon reflexes, that is knee jerk, which is also called as patellar jerk. So knee jerk, the root value is the L3 and as well as L4, and then followed by that the ankle jerk. The ankle jerk, the root value it is L5 and S1. And next is the plantar reflex. The plantar reflex, it is the superficial reflex, right? So up to ankle jerk, these are the deep tendon reflexes, whereas you take the plantar reflex, which is also a polysynaptic reflex. So this plantar reflex root value predominantly it is the S1. Then jaw jerk, like within the face, which is like mediated by fifth cranial nerve, that is trigeminal nerve. Next is cremasteric reflex. This is also a superficial reflex. This is dependent on the nerve roots L1 and as well as the L2. In case of cremasteric reflex, this reflex is elicited by stroking the superior and medial part of the thigh in the downward direction. And what is the normal response? If in males, you have the contraction of the cremasteric muscles that pulls up the scrotum and testis on the side, whichever side is being stroked. So that is what is your cremasteric reflex. So these are the root values for the various deep tendon reflexes and as well as the superficial reflexes, right? Next question. Which of the following are the diseases associated with DNA repeat sequences? Huntington's disease, myotonic dystrophy, Friedreich's ataxia, Klinefelter syndrome. So Huntington's disease, myotonic dystrophy and the Friedreich's ataxia, these three, they are associated with the DNA repeat sequences, but not the Klinefelter syndrome. So first, if you take the Huntington's disease, this is caused by expanded, right? This is caused by expanded CAG trinucleotide repeat. Right, CAG trinucleotide repeat in HTT gene, right, in the HTT gene. And what is the effect whenever there is expanded CAG trinucleotide repeat? The greater is the number of repeats, the earlier the onset of the disease. Okay, so more is the number of repeats, earlier it is the onset of disease and more severe the symptoms. So that will be the effect of the more number of repeats, that is expanded CAG trinucleotide repeat. And the next one is myotonic dystrophy. This is also due to a trinucleotide repeat, and this is caused by CTG trinucleotide repeat. Right, so this is caused by CTG trinucleotide repeat expansion, and the gene that is being defective here is DMPK gene, right? DMPK gene, that is for myotonic dystrophy type 1. Okay, so DM1, it stands for myotonic dystrophy type 1. And the other important form of the repeat will be CCTG, right? CCTG tetranucleotide repeat expansion, right? and the gene that is being defective is CNBP gene that is being defective, and it is DM2 myotonic dystrophy type 2 that is being defective here, right? And what is the effect? The number of repeat affects the severity of and the onset of the disease. Okay, so more is the number of repeats, more severe is the disease, right? More severe is the disease. So that is the myotonic dystrophy. Then Friedreich's ataxia. Friedreich's ataxia, this is caused by a, right, this is caused by GAA trinucleotide repeat. Right, so GAA trinucleotide repeat expansion, and the gene that is being defective in case of the Friedreich's ataxia is FXN gene. That is the gene that is being defective in Friedreich's ataxia. And what is the effect? The length of repeat expansion correlates with the severity of the disease. Okay, so more is the number of repeats, right? More severe is the disease in case of the Friedreich's ataxia. So these three, Huntington's, myotonic dystrophy and Friedreich's ataxia, it is mainly because of the repeats. Whereas you take the Klinefelter syndrome was another option for us. Klinefelter syndrome, it is not due to a trinucleotide repeat. It's a chromosomal disorder which is characterized by the presence of the extra X chromosome, right, where you have 47, right, 47 XXY. And this condition, it is not caused by DNA repeat expansion, but it is a numerical chromosomal anomaly. That is what is your Klinefelter syndrome. Then, if you see the detailed discussion of the Friedreich's ataxia, it is an inherited disorder, and the gene that is being mutated is frataxin gene, and it is an autosomal recessive type of inheritance. And the another name for the Friedreich's ataxia is, it is also called spinocerebellar ataxia, right? Spinocerebellar ataxia. Then the gene and the chromosome that is being defective is, it is the frataxin gene that is being defective, and the chromosome number on which this frataxin gene is present is on chromosome 9. And this spinocerebellar ataxia, we have multiple types, but the one which is most common in India, that is spinocerebellar ataxia type 2, whereas most common all over the world will be spinocerebellar ataxia type 3, right? And if you take the pathology here, it is mainly the involvement of the dorsal root ganglia. That is the first major abnormality seen in Friedreich's ataxia, and followed by the dorsal root ganglia, right? You have the degeneration of corticospinal tract, degeneration of the posterior columns, degeneration of spinocerebellar tract, and there is also degeneration of the peripheral nerves. But the first major structure that is affected is dorsal root ganglia. Then degeneration of corticospinal tract, posterior column, spinocerebellar tract, and peripheral nerves, right? And the clinical features, if you observe, ataxia is the initial symptom. And the ataxia that you have here is both sensory and as well as the cerebellar type. And these patients, because of the sensory ataxia, they walk with feet wide apart. So this is like wide based gait, and Romberg sign will be positive, and the other cerebellar manifestations, right? There will be dysarthria, there will be dysmetria, and there can be also horizontal nystagmus. And the associated features that these patients will have is the presence of the pes cavus. Then there will be also kyphoscoliosis. Cardiomyopathy is present in almost 20% of patients. Diabetes mellitus is present in 20% of patients. There will be optic atrophy and as well as dementia. These are the associated features in case of the Friedreich's. And so this is what is your high arched foot. So this is what is your pes cavus. Okay, and what is the unique feature of the Friedreich's ataxia is, in these individuals the ankle jerk is absent, right? So ankle jerk absent is a feature of lower motor neuron palsy, but plantar reflex, it is upgoing, that is Babinski sign, which is a feature of the upper motor neuron palsy. Why? Because the ankle jerk is lost due to pathology of the peripheral nerve, and the plantar reflex is upgoing, that is because of the involvement of the corticospinal tract, right? And in these individuals with Friedreich's ataxia, what is the cause of death? The cause of death, it is due to development of cardiomyopathies. So cardiac disease is a cause of death in case of Friedreich's ataxia. And how do you work up these patients? You need to do the electromyography, right, or the nerve conduction studies, and you need to check the conduction velocity in the motor fibers, right? You need to check the conduction velocity in the motor fibers. So this will be the investigations. And how do you treat? See, in these individuals you have the severe form of muscle weakness, so the physiotherapy or proper training, that is important in case of the Friedreich's ataxia. So we don't have any particular drug that will completely reverse the disorder. It is completely physiotherapy which helps a lot in this individual. So this is about the Friedreich's ataxia. Then next important is the Huntington's chorea. So Huntington's chorea, it is due to the gene that is being defective, Huntington gene, and the defect of this Huntington gene, it is present on chromosome number 4, right? Huntington gene is present on chromosome number 4, and the type of inheritance is autosomal dominant type of inheritance. Okay, and the gene that is being mutated is Huntington gene. And in these individuals, the protein, abnormal protein that gets accumulated within the neurons will be ubiquitin. So it is the ubiquitin that gets accumulated within the neuron, right? And in these individuals, because of abnormal protein accumulation, that will result in the development of dementia. And this dementia, it represent the neuronal death, right? So it represents the neuronal death. And in these individuals, there is also neuronal degeneration as well. Neurodegeneration within the brain, this is due to iron accumulation. This is due to iron accumulation. And this Huntington's chorea, what is the earliest manifestation? The earliest manifestation is the development of chorea. And what is the age group at which you see this Huntington's? It is around the age of 40 to 50 years. Okay. And in these individuals, along with chorea, there is like memory loss. So initially, like there will be, okay, so memory loss. So initially there will be like short-term memory loss, and that will be followed by long-term memory loss that will be present. And the MRI, and these patients will also have rigidity, that is the stiffness. So upper limb you have cogwheel rigidity, and lower limbs you have lead pipe rigidity. MRI will show you the presence of boxcar ventricles, right? MRI will show you the presence of the boxcar ventricle. So this is what is the representation of the boxcar ventricle. And how do you treat these patients? So the treatment in these individuals is tetrabenazine. Okay, so tetrabenazine is given, and tetrabenazine is what? It is the dopamine depleter, that is the tetrabenazine, right? And in these individuals, the dopamine is present in excess quantity in Huntington's disease. So levodopa, it is contraindicated in case of the Huntington's disease or the Huntington's chorea. So this is about the Friedreich's ataxia and as well as the Huntington's chorea, right? Next question. Which of the following are correct regarding the essential tremors? It may present at any age. Head is almost never involved. Tremor may improve with small amounts of the alcohol. So it may this essential tremors, it may present at any age. And head almost never involved is a wrong statement. Head can be involved in case of the essential tremors. And tremors will improve with small amount of the alcohol. So the correct answer is 1 and 3. So if you take these tremors, depending upon the frequency, like we have the high frequency and low frequency tremors. High frequency tremors is that like where the frequency is more than or equal to 8 hertz. And you see that in case of the anxiety neurosis, this is one condition. And the second important condition is the Graves' disease or thyrotoxicosis. So these are the two conditions where you have the presence of the high frequency tremors. And low frequency tremors are those where the frequency of the tremors is less than 8 hertz. And intentional tremors, and these intentional tremors, you see that in case of cerebellar damage where the frequency is around 5 hertz, right? And next is the resting tremors of Parkinson's disease where the frequency is around 4 to 6 hertz. So these are the low frequency tremors. So high frequency tremors where the frequency is more than 8, anxiety neurosis and Graves' disease or thyrotoxicosis. Low frequency tremors where the frequency is less than 8 hertz, that is intentional tremors of cerebellar damage and resting tremors of Parkinson's disease, right? Next question. Yeah, so this is like almost a repeat question. Which of the following are suggestive of Parkinson's disease? Lead pipe rigidity, cog-wheel rigidity, Festinate gait and Romberg sign positive. So lead pipe rigidity will be there in the lower limbs, cog-wheel rigidity will be there in the upper limbs, and Festinate gait will be there in patients with Parkinsonism. And Romberg's test positive, that is a feature of cerebellar damage, but that is not the feature of Parkinsonism. So the correct answer here is 1, 2 and as well as 3.